Hello everyone, in this lecture we are going to continue our discussion of integrative cardiovascular pharmacology, and today specifically we will focus on ischemic heart disease. Ischemic heart disease, in short IHD, is the leading cause of mortality in the United States and accounts for more than 500,000 deaths each year. Since the advent of cardiac intensive care units in the early 1960s, an improved understanding of the biology of ischemic heart disease has resulted in a spectrum of diagnostic and therapeutic advances. These advances, coupled with increased public awareness, healthier lifestyles, and sustained efforts to improve both primary and secondary prevention strategies, have resulted in significant mortality reduction for patients with IHD. Ischemia means lack of oxygen, or more broadly, lack of oxygenated blood supplying specific tissue. Ischemic heart disease is essentially a defect in supplying oxygen to the heart, and it can be further subclassified into two broad categories. First, chronic coronary artery disease and the acute coronary syndromes. Each of these clinical presentations of IHD has a distinct pathogenesis, and as a result, the pharmacologic strategies employed to treat these distinct clinical entities differ in emphasis. The therapeutic goal in patients with chronic coronary artery disease is to maintain the balance between myocardial oxygen supply and demand. In patients with acute coronary syndromes, the goal is to restore and/or maintain potency of the coronary artery lumen. The pathogenesis of the two subclasses of IHD pertains to progression of atherosclerosis, which is a pathological condition characterized by development of lesions in walls of arteries. And by lesions, we specifically mean here various stages of the sclerotic plaque development. You can see here schematic representing stages of coronary artery disease. Healthy large arteries, so we are over here, okay, these are bounded on the luminal side by a monolayer of endothelial cells that form tight junctions, insulating the vessel wall from the blood. Underlying this is a region called the intima, which consists largely of proteoglycans and collagen. This is followed by layers of smooth muscle cells, and then an outer region, the adventitia, comprising fibrous elements and fibroblasts. Right? The first stages of atherosclerosis are characterized by the accumulation of lipoproteins, particularly the low-density lipoproteins, the LDLs, which carry the unabsorbed or leftover lipids, including cholesterol, fat, and others, in the intimal region. In response to the lipoprotein accumulation, monocytes and subsequently lymphocytes infiltrate the vessel wall. The monocytes differentiate to macrophages, which then take up lipoproteins to give rise to cholesterol-engorged so-called foam cells, which is a hallmark of early atherogenesis. And you can see this over here. Okay, this is the stage. Some of these foam cells eventually die, resulting in a necrotic core of cholesterol and cellular debris. This is accompanied by the migration and proliferation of smooth muscle cells, which form a fibrous cup that overlays the necrotic core. This stage is referred to as atheroma. So on our schematic, we are here now. Okay, this is called early atheroma, and you can see here, the fibrous cup. Okay, so the gray area overlying the lipid-rich necrotic core. Okay, this fibrous cup is an important element here. Please remember that. Okay, now depending on the way the atheroma develops, it turns into the plaque that is either stabilized by thickening of the fibrous cup without development of the lipid pool, which on our schematic is over here. Okay, or the vulnerable plaque with buildup in the lipid necrotic core and thin fibrous cup, which is represented over here. The vulnerable plaque formation is a borderline before which we deal with the chronic coronary artery disease, so this part, and after which we will talk about the acute coronary syndrome, so acute conditions over here. Notably, this stage, so the vulnerable plaque, is still manageable by introducing therapies or lifestyle changes that will reduce the vulnerable plaque's lipid core, promoting its stabilization. For example, if you remember from biochemistry, the high-density lipoproteins, the HDLs, the good lipoproteins, can penetrate the plaque and pick up the remnants of LDLs and carry them over to the liver for excretion. If, however, the condition is not mitigated, the vulnerable plaque will rupture, leading to formation of this so-called thrombus, this part, the inside part over here. And thrombus will block the flow of blood and will lead to most commonly myocardial infarction, which is a type of heart attack that occurs upon the described condition and resulting tissue death to the heart muscle. Which the word infraction specifically means. So let's focus now on the chronic coronary artery disease, or in short, chronic CAD. Chronic CAD is specifically characterized by impaired coronary vasodilator reserve, which is the maximal blood flow through coronary arteries. It is particularly relevant under stress conditions that require increased coronary blood flow, as it can result in an imbalance between myocardial oxygen supply and demand, leading to functional cardiac abnormalities such as poor contraction of the ischemic portion of the myocardium and leading to clinical manifestations, i.e. various types of angina, which we will talk about in a sec. Imbalances in myocardial oxygen supply and demand occur mainly as a result of either coronary flow reduction, for example due to atheroma, represented in this schematic over here, or the endothelial dysfunction, which is a dysfunction of the lining of the arteries, and represented over here. And let's talk about these in more detail. First, coronary flow reduction. Here you can see the heart schematic with the inset representing the organization of myocardial tissues. The innermost layer of pericardium is the epicardium, so we are over here. Okay. Then further in depth, epicardium is followed by the actual myocardial muscle, this part, okay, and then the innermost endocardium, so this part over here. The coronary vasculature is composed of two types of vessels, large epicardial vessels and small endocardial vessels. The epicardial vessels, so they will be located over here, okay. So this is our epi, okay. These vessels are the more frequent sites of atheroma and plaque formation. In disease states, total coronary artery blood flow is limited by the extent of epicardial vessel stenosis, which is their narrowing that prevents blood flow from passing through as easily as it should. Okay, please remember, stenosis, narrowing of the lumen of the vessels. In comparison, the endocardial vessels, so now we are over here, our endo, okay, the endocardial vessels dilate in response to local metabolic factors, resulting in a regional increase in myocardial blood flow, and thereby providing increased oxygen to these metabolically active tissues, increasing at the same time a need for oxygenated blood from the epicardial vessels. In other words, typically CAD pertaining to coronary flow rate reduction will not be much problematic at rest. But once you will make some activity that will trigger metabolic signaling to increase the oxygen, the endocardial vessels will dilate in order to provide for that need, as well as receive the large supply of blood from more proximal epicardial vessels. These, however, when obstructed due to, for example, atheroma, will not meet the demand, leading to ischemic state. This graph provides somewhat a mechanistic explanation of why the coronary flow reduction based CAD is manifested characteristically upon increased heart blood demand. The coronary flow reserve is a proportion between the maximal coronary flow, over here, and the resting coronary flow. In healthy individuals, the maximal coronary blood flow is approximately 5-fold greater than the resting coronary blood flow. This difference assures important wide safety margin of blood supply from which resting coronary flow can draw, remaining unchanged despite the progression of the plaque development and stenosis of the coronary lumen, up to even 90% of the original arterial diameter. However, when the maximal blood supply is needed, for example upon an exercise, the coronary stenosis does not allow to meet it, resulting in the coronary flow reduction. Take a look at the highlighted window over here. So from about 40% to about 90% stenosis, we will observe the described effects. So the resting flow remains unchanged for such a long window, so to speak, whereas the maximal flow, so maximal volume flowing through coronary system, is being reduced more rapidly. So, for example, if your chronic coronary artery disease progressed to reduce your artery lumen to by about 60%, so we are over here, okay? At rest, you won't really notice much because the minimal blood flowing through your coronary system is still met. However, if you are going to, for example, exercise and increase the need for your blood, for this level of blood in your coronary system, you won't be able to meet it because the obstruction of your arteries is only allowing that much of blood. So this difference is going to be not met. And of course, this difference between the need and what your system can supply due to obstruction in the arteries is going to progress more and more rapidly, eventually leading to development of ischemic state. Clinically, coronary flow reduction will commonly manifest as angina pectoris. Angina pectoris is a symptom characterized by precordial pressure-like discomfort resulting from myocardial ischemia. Most patients with chronic CAD experience this specific subtype of angina called the stable or sometimes exertional angina. As we just discussed, in this condition, the ischemic chest pain occurs at characteristic and reproducible workloads, walking up the stairs, for example, or in other words, at times when an effort undertaken increased blood supply demand. Pathologically, chronic CAD is associated with subintimal deposition of atheroma in the epicardial coronary arteries, which with an overlaying fibrous cup that is thick and resistant to disruption. So, in other words, very easy to remember, stable angina, stable plaque. Okay, stable angina over here, and this is our stable plaque covered by our fibrous cup over here. Moving on to the second condition underlying chronic CAD, the endothelial dysfunction. Endothelial dysfunction is a general term for pathologic endothelial cell regulation. Note here our endothelial cells layering the vessel, so here we are, inside the lumen. Clinically, endothelial dysfunction is manifested by 1. Vascular tone, and 2. Prothrombotic properties. Abnormal vascular tone, so the first option, is a result of dysregulated endothelial control of smooth muscle contraction. Arterial beds with endothelial dysfunction cannot dilate in response to hyperemic stimuli. For example, when mental stress or physical exertion triggers activation of the sympathetic nervous system, two opposing forces act on the coronary vascular endothelium: catecholamine-mediated vasoconstriction and nitric oxide-mediated vasodilation. Normally, endothelial release of nitric oxide is stimulated by the shear stress on the coronary vascular endothelium that results from increased blood flow. Eventually, the vasodilator effect of nitric oxide predominates over the vasoconstrictor effect of the sympathetic nervous system. And the overall effect is coronary vasodilation. However, when the vascular endothelium is damaged, the production of endothelial vasodilators is decreased and catecholamine-mediated vasoconstriction predominates. The second manifestation of the endothelial dysfunction pertains to its crucial role in hemostasis, which is the system that keeps blood clot-free in normal vessels, whereas in the injured vessels, it promotes rapid plaque formation. More specifically, in healthy vessels, endothelial-derived nitric oxide and prostacyclin, specifically the PGI2, exert significant antiplatelet effects, which collectively, with other molecules on the surface of healthy endothelial cells, preclude coagulation. Conversely, endothelial damage decreases the ability of the endothelium to utilize these endogenous antiplatelet and anticoagulant mechanisms, leading to a local predominance of procoagulant factors and increasing the likelihood of blood coagulation, which is technically called thrombosis. The schematic here represents stages of the hemostatic process, and let me just go over it briefly. The hemostatic process can be divided conceptually into 4 stages: vasoconstriction, primary hemostasis, secondary hemostasis, and resolution. These stages are temporarily overlapping and may happen nearly simultaneously. First, vascular injury causes endothelial denudation or exposure of the intima. Okay, so here we are. Endothelin, released by activated endothelium, and neurohumoral factors induce transient vasoconstriction. In second stage, so we are over here, injury-induced exposure of the subendothelial collagen matrix in the intima provides a substrate for platelet adhesion and activation. So that will be here. In the granule release reaction, activated platelets secrete thromboxane A2 and ADP. Okay, so we are at the stage number 2, which is actually over here, and we have secretion of TXA2 and ADP. Both factors released by the activated platelets cause nearby platelets to become activated. These newly activated platelets undergo the shape change. So we are now at the point 4, and please note, so we have this green sphere is representing inactive platelet, and then it changes to more triangular blue platelet, and that is representing the pertaining shape change upon the activation by our thromboxane and ADP. These activated platelets are then recruited to the site of injury, where they facilitate formation of the primary hemostatic plug, which is our 5 and 6. Certain aspects of the primary plaque formation are a target for some of the major drugs that we will discuss later, and so let's talk about that in more detail. So the primary plaque, which is a reversible clot, is essentially an aggregate of platelets. In the first reaction, platelets adhere to the subendothelial collagen that is expressed after vascular injury, and in our schematic these are those white stripes over here. Okay? The adhesion is mediated initially by 2 molecular interactions. First, von Willebrand factor, marked here in green, which is a large multimeric protein that is secreted by both activated platelets and the injured endothelium, binds both to the surface receptors on the platelet membrane, especially glycoprotein 1b, GP1b over here, so orange in our schematic, as well as to the exposed collagen on this side. Okay? This bridging action mediates adhesion of platelets to the collagen. Second, platelet glycoprotein 6, GP6, so here in yellow on our schematic, okay, it interacts directly with collagen in the exposed vessel wall. Now, both the GP1b von Willebrand factor collagen interaction and the GP6 collagen interaction are required for initiation of primary hemostasis. Adherent platelets undergo a process of activation during which the cell's granule contents are released. Specifically, stimulation by collagen interaction as well as ADP and epinephrine leads to activation of platelet membrane phospholipase A2. So we are over here. This is phospholipase A2 and this is our platelet membrane. Okay. Phospholipase A2 cleaves membrane phospholipids and liberates arachidonic acid, very important molecule to remember because it is a precursor of whole range of what we call prostaglandins. And you might, whoever took biochemistry with me, you might remember we talked about it. But here in this context, it is important because arachidonic acid is converted into a cyclic endoperoxide by platelet cyclooxygenase. And cyclooxygenase enzymes are very important as well. In other tissues, they are mediating exactly synthesis of other prostaglandins that are mediating inflammation, for example, or pain. And cyclooxygenases are targets of non-steroid anti-inflammatory drugs. We are going to actually talk about this effect when administered aspirin, but also Tylenol or Advil, what you take on regular basis, are targeting exactly that, cyclooxygenase, so something worth to remember. But in this particular context, the product of the cyclooxygenases is a substrate for the synthesis of thromboxane A2, the one that we mentioned over here. Thromboxane A2 is released from our platelets. And this molecule, via G protein coupled receptor, causes vasoconstriction at the site of vascular injury and stimulates the granule release reaction within other platelets. Thereby, thromboxane A2 is propagating the cascade of platelet activation and vasoconstriction. It also promotes platelet aggregation through signaling cascades, resulting in the expression of functional, and this is important, GP2B and 3A integrins. Okay, GP2B and 3A integrins. Very important to remember because these will be a target to a major drug group, which we're going to discuss later on. Okay, as you can see from the schematic, these integrins are important mediators of platelet aggregation. Now, during the release reaction, large amounts of ADP, so another part over here, ADP, as well as other molecules such as calcium ions or serotonin, etc., are secreted from platelet granules. ADP is particularly important in mediating platelet aggregation, causing platelets to become sticky and adhere to one another. More specifically, ADP triggers platelet activation by binding to G protein coupled ADP receptors, specifically P2Y1 receptor and P2Y ADP receptors, and I only name these because you might encounter these abbreviations when we will be studying. But in general, activation of these receptors on the platelet surfaces mediates platelet shape change and expression of functional, again, GP2B 3A integrins. So, in other words, both thromboxane A2 and ADP are potent initiators of expression and of the GP2B and 3A integrins. Now, as shown on this illustration over here, GP2B and 3A are bridged by a very important molecule called fibrinogen. Okay? Fibrinogen bridges platelets aggregating with each other. It has multiple binding sites for the functional GP2B 3A integrins, just as the von Willebrand factor GP1B interaction is important for platelet adhesion to exposed subendothelial collagen. The fibrinogen GP2B 3A interaction is critical for platelet aggregation. Platelet aggregation ultimately leads to the formation of a reversible clot, or what we call primary hemostatic plaque. And let's go back to our schematic. In the third stage over here, the tissue factor expressed on activated endothelial cells, so we are on the stage 1, and leukocyte microparticles, which are not shown here, together with acidic phospholipids expressed on activated platelets and activated endothelial cells, initiate the steps of coagulation cascade, okay, culminating in the activation of thrombin. Thrombin proteolytically activates fibrinogen to form fibrin, which polymerizes around the site of injury, resulting in the formation of definitive secondary hemostatic plaque. Since the coagulation cascade and consequently formation of secondary plaque is also a target for some of the major drugs, let's discuss this process in greater detail as well. Activation of the coagulation cascade proceeds nearly simultaneously with the formation of the primary hemostatic plaque. It leads to generation of fibrin. Please check the schematic, I just highlighted it here. Initially, at the periphery of the primary hemostatic plaque. Platelet pseudopods, and take a look at these pictures over here where you can actually see conversion of platelets from the resting form to activated spread platelet to activate contracted platelet. You can see the pseudopods. So these pseudopods attach to the fibrin strands at the periphery of the plaque and contract. Platelet contraction yields a compact, solid, irreversible clot, or what we call a secondary hemostatic plaque. Schematic on the left is representing a detailed view of the coagulation cascade or the secondary hemostasis. The cascade is a sequence of enzymatic events. Most plasma coagulation factors circulate as inactive proenzymes, which are synthesized by the liver. These proenzymes are proteolytically cleaved and thereby activated by the activated factors that precede them in the cascade. The activation reaction is catalytic and not stoichiometric. For example, 1 unit of activated factor X can potentially generate 40 units of thrombin, factor 2A. This robust amplification process rapidly generates large amounts of fibrin at a site of vascular injury. Please note that on this schematic, our activated enzymes are colored in blue, whereas the inactive proenzymes are colored in black. Secondly, the major activation reactions in the cascade occur at sites where a phospholipid-based protein-protein complex has formed. Please note, we have a piece of membrane depicted over here, okay? This complex is composed of a membrane surface provided by activated platelets, activated endothelial cells, and possibly activated leukocyte microparticles, an enzyme, which is an activated coagulation factor, a substrate, the proenzyme form of the downstream coagulation factor, and a cofactor. So let's take a look over here, for example. So we have our membrane, we have our enzymes, two actually of them, 5A and XA, we have cofactor, which is calcium, and we have our substrate, which is going to be protothrombin. It's going to come over here and leave after the cleavage as an active thrombin. Okay. The presence of negatively charged phospholipids, especially phosphatidylserine, is critical for assembly of the complex. Phosphatidylserine, which is normally sequestered in the inner leaflet of the plasma membrane translocates to the outer leaflet of the membrane in response to agonist stimulation of platelets, endothelial cells, or leukocytes. Calcium is required for the enzyme, substrate, and cofactor to adopt the proper conformation for the proteolytic cleavage of a coagulation factor proenzyme to its activated form. For the third part, the coagulation cascade has been divided traditionally into the intrinsic and extrinsic pathway. The division is a result of in vitro testing and is essentially arbitrary. The intrinsic pathway is activated in vitro by factor 12, which is also called Hagemann factor, while the extrinsic pathway is initiated in vivo by tissue factor, activated endothelial cells, subendothelial smooth muscle cells, and subendothelial fibroblasts at the site of vascular injury. Although these two pathways converge at the activation of factor X, which is over here, okay, there is also much interconnection between the two pathways, and you can spot them. Because factor 7, activated by the extrinsic pathway, can proteolytically activate factor 9, a key factor in the intrinsic pathway. So let's take a look. This is factor 7, okay, 7A, and 7A is activating here the factor 9 over here. So because the activation of factor 9 depends on factor 7, the extrinsic pathway is regarded as the primary pathway of the initiation of coagulation in vivo. For the fourth information, both the intrinsic and extrinsic coagulation pathways lead to the activation of factor X, as we just said. Now, in an important reaction that requires factors 5, activated factor X proteolytically cleaves prothrombin, which is factor 2, to thrombin, which is factor 2A. Thrombin acts in the coagulation cascade in 4 important ways. Okay, this is a very key element over here. Firstly, it converts the soluble plasma protein fibrinogen to fibrin, as we just said, and then fibrin then forms the long insoluble polymer fibers. Second, thrombin activates factor 13, which cross-links the fibrin polymers into a highly stable meshwork or clot. And this is this part over here. Third, thrombin amplifies the clotting cascade by catalyzing the feedback activation of factors 8 and 5. And 4, thrombin is strongly activating platelets, causing granule release, platelet aggregation, and platelet-derived microparticle generation. Now, importantly, in addition to those procoagulant properties, thrombin also acts to modulate the coagulation response, essentially mitigating the secondary hemostasis. Thrombin activates protease-activated receptors on the intact vascular endothelial cells adjacent to the area of vascular injury and stimulate these cells to release a platelet inhibitor prostacyclin PGI2, so molecule that is going to actually suppress formation of the secondary plaque. In addition, the vasodilating nitric oxide will be released, and other profibrinolytic protein factors like profibrinolytic protein tissue plasminogen activated TPA and others. And let's go back to our schematic because this is actually part of the stage 4. In the last stage, number 4, natural anticoagulant and thrombolytic factors limit the hemostatic process to the site of vascular injury. These factors include tissue plasminogen activator, TPA, shown over here, okay, which activates the fibrinolytic system, thrombomodulin, which activates inhibitor of coagulation cascade, and prostacyclin, which we mentioned before, PGI2, which inhibits both platelet activation and vasoconstriction, and surface heparin-like molecules, which catalyze inactivation of coagulation factors. Okay, and they are not really shown here. Coming back to the endothelial dysfunction, such pathologic condition will impede the 4th stage, depraving the hemostatic process of the factors mitigating the formation of the hemostatic plug, thus allowing it to grow even further, progressively obstructing the blood flow through the affected vessel, gradually advancing towards ischemia and myocardial infarction. Let's now discuss the acute coronary syndromes. So the acute coronary syndromes are most often caused by rupture of the vulnerable plaques. Plaque rupture results in the exposure of procoagulant factors such as subendothelial collagen that activate platelets and the coagulation cascade that we just talked about. And similarly to the case of chronic endothelial defects, while under physiologic circumstances hemostasis at site of vascular injury is self-limited by endogenous anticoagulant mechanisms, the deleterious effects of the plaque on the overlaying it endothelium preclude the release of sufficient anticoagulant factors to control the extent of the clot formation. This regulation of coagulation can then result in the formation of the intraluminal thrombus. So this big structure inside the lumen over here is called thrombus, okay? And thrombus can lead to myocardial ischemia and potentially to irreversible myocardial injury. Please note that this condition, as opposed to chronic condition, chronic endothelial dysfunction that builds with time, this condition is acute and strikes suddenly and immediately, and basically hinges on the rupture of the plaque, and the consequences follow immediately after that. There are three subtypes of the acute coronary syndromes, and these are unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. In unstable angina, patients experience either acceleration in the frequency or severity of chest pain, new onset anginal pain, or characteristic anginal chest pain that abruptly occurs at rest. Enzymatic evidence of tissue infarction, for example, elevated troponin levels, is absent in unstable angina, but patients are at high risk of the myocardial infarction because of the presence of an active prothrombotic surface at the site of plaque rupture and gradual progression of the clot formation. So there you go, and here is our thrombus. The non-ST elevation myocardial infarction occurs when an unstable plaque abruptly ruptures and significantly compromises, but does not completely occlude, the lumen of an epicardial coronary artery. Because the artery is partially occluded and there is a persistent prothrombotic surface at the site of plaque rupture, patients with the non-ST elevation myocardial infarction are at high risk of reoccurrence of ischemia. The pathophysiology and clinical management of unstable angina and the non-ST elevation myocardial infarction are very similar, and these two syndromes are often referred to by combined acronym unstable angina / non-ST elevation MI. The non-ST part of the name refers to the EKG plot, electrocardiogram plot, which you can see over here, okay? This is the normal cardiac rhythm, and when the myocardial infarction occurs, lack of changes to the ST interval, so please note here is our ST interval, it will be lasting over here. So lack of changes really to the height of this interval are the differential for the non-ST MI as opposed to the ST elevated myocardial infarction. Please compare the change to the ST interval here and here. And really what we mean by elevated is the actual elevation of the ST interval's baseline or level, okay, compared to it being at the basal level over here. So the ST elevated MI is the third acute coronary syndrome, and it signifies a total blockage of one of the heart's main supply arteries. So it is completely shut at this point. And if the thrombus blocks the artery completely, then the blood supply to that region in heart ceases. This, if persists, will lead to the myocardial injury, which progresses inexorably to transmural infarction unless perfusion is reestablished. In about 30% of patients, the ST elevated acute coronary syndrome manifests as a sudden cardiac death. In these cases, death is usually caused by ischemia-induced electrical instability of the myocardium. In the remaining cases, in the absence of fatal electrical instability, ST elevation MI typically presents with unremitting chest pain that is often accompanied by shortness of breath and ischemic left heart failure. Mortality in this condition is significantly reduced by prompt relief of the complete epicardial obstruction. Therefore, the principal management goal is expeditious reperfusion of the occluded artery. Here you can see another schematic of blood clot formed over the thrombus resulting from the ruptured plaque. And on the right, you can see a photographic image of the actual blood clot in the coronary artery. I hope that you can appreciate how extensive and voluminous the clot is, which really reflects how resistant really our coronary system is to the obstruction. It took such accumulation of the clot to seize the action of the heart muscle.
Ischemic heart disease occurs when the blood supply to the heart is reduced or obstructed. This leads to insufficient oxygen and nutrient delivery, resulting in heart muscle damage or dysfunction. The condition is primarily caused by atherosclerosis, the accumulation of fatty deposits, or plaques, within the arterial walls. Over time, these plaques can harden and narrow the arteries, restricting blood flow. Sometimes, a plaque may rupture, triggering the formation of a clot that further obstructs the coronary artery, potentially leading to angina, myocardial infarction, heart failure, or sudden cardiac death. Risk factors for ischemic heart disease include age, gender, family history, smoking, high blood pressure and cholesterol, obesity, diabetes, and stress. The disease can be managed by lifestyle changes and medications such as aspirin, angiotensin-converting enzyme inhibitors, organic nitrates and beta blockers. In more severe cases, invasive procedures like angioplasty or bypass surgery may be needed to restore adequate blood flow to the heart.
We're going to finish lecture 13 at this stage, and lecture 14 is going to be dedicated to pharmacology of our ischemic heart disease, so stay put.